we'll be beginning with the second live case. So this is the brief clinical history. This is a 37-year-old gentleman who is a known case of diabetes and dyslipidemia and has a significant family history of coronary artery disease. His baseline creatinine is at 62 millimoles with an EGFR of 60. He presented with complaints of chronic fatigue and dyspnea on exertion. An initial ECG showed poor progression of R waves in the anterior chest leads, and a baseline echo revealed an EF of 35%, global LV hypokinesia, and a dilated LV with a 6.1 to 4.7 dimension. His coronary angiography was done on the 15th of October, which revealed triple vessel disease with a CTO RCA and a CTO LCX. So, the indication for CTO intervention in this gentleman is, first of all, he's been having chronic fatigue and dyspnea despite optimal medical therapy, and in view of a young age and severe LV dysfunction and viable myocardium, it's opted for complete revascularization by the heart team. So I'll be showing you the patient's angiogram over the next couple of slides. So the JCTO score for the RCA CTO was 1 for the CTO length, and the JCTO score for the LCX was 2, 1 for the entry shape and 1 for the length.
So I think because people are eating, we will just go live upstairs and let's see where our colleagues up in the cath lab, where they are, and they can show us their angiographic shots, what they've done so far.
The proximal cap is clear, or at least we know where to start. The lesion length is unsure, but it's sort of 20-25 millimeters. There's not really a good landing zone because there's a large branch at that. And then to the REO30, go forward another one. And there are interventional collaterals. Okay? And then, so if you go back, we feel this was a wire escalation with a retrograde bailout for the right coronary.
Yeah, we're struggling with sound guys still to sort of intermittently come in, come out.
Yeah, and your sound's very poor as well. But anyway, we'll show you what we did and we'll move on.
Well, I think we got the message that you're going to do aggregate wire escalation and you've got a retrograde bailout. So yep. Why don't you keep going and somebody can work on the technical side.
And then the CERT we'll come back to in a second. So we started with an AL guide. There was a lot of pressure damping, so it was either all in or all out. So we put a wire down, an anchor wire. Go forward. Yep, play that. And we started with a Fielder XT. And the reason for storing this, if you see the way the Fielder behaves, once it starts to buckle like that, it is not going to go through the cap.
You think that Colin said, it's buckling against the cap. You can see it buckling here.
So that's done.
Yeah, so it's
you have to escalate up. Next one. And play that. This is then a Pilot 200.
So Pilot 200 is a 4.7 gram polymeric wire. You look at the caps now engaged here.
So
just
looks
past
good.
the early branch.
And seems to be making progress. Corsair, 135 centimeter Corsair. But what happens is that this all prolapses out because of resistance at the proximal cap. So what we then switched to was a parallel anchor. Okay, go forward now.
Trapping the Corsair, and that's just to try and add a bit of support to it.
So we switched actually to JR4 with a parallel anchor. Next one.
So the guide is now being changed to a JR4 instead of an AL1, and that's because the AL1 wasn't sitting due to damping.
Next one. So what we've got is the microcatheter. Yep. And then there's a Pilot 200. So the exact same wire exact same microcatheter, but with a parallel anchor. Next one. And this is all, Husam, we do a retrograde injection. Next. And this is all field. So if you watch this, Husam gets the pop and release that Jono had the last case. So still at the pilot. So see the way it's buckling at the distal cap, then a little bit of forward pressure so you know that you're right. If you just go back one picture.
You've got to trap up the whole time there as a way of just stabilizing the guide.
So this cine is to ensure that we're not beyond the distal cap. We're taking our time coming down through the occlusion. If we go to the next one. This wire is at the distal cap, play that. You can see the resistance, you can see it buckling. So the wire's turning around to 4 or 5 o'clock, starting to buckle, and then it goes.
Buckling here, and then it's popping into the distal vessel.
And then next one. So then we went cranial. We did a cine, and when we contrast in the distal vessel, we move the wire on, and so the wire's in the true lumen distally.
Great, well done.
Yeah, so well done, Sam.
Would clap call, but they're too busy slapping their face.
Yeah, exactly.
Perhaps there's clapping in the audience.
And I think it's well worth persevering with a. We suspect this is a recent-ish occlusion. It certainly looked soft. It felt soft when your first wire. So we didn't think we lost anything by doing this. So what we have done is we have switched out for a workhorse wire. We're about to pre-dilate the track.
Would it be reasonable to assume that case was rapidly successful due to the new scrubs? Would that be reasonable to assume that?
I can't make out, no. We'll take a balloon, 2520 balloon, please.
I think you have to write on the banner there
yep.
so we can see what you're talking.
Well,
no wire language.
It's a Henrati wire case anyway.
Later.
Great. So is the microcatheter advanced past the distal?
Yeah, next one. Yep. So Corsair Pro into the distal vessel and then switch to workhorse wire. Next one. With an injection retrograde. This is the Sion Blue into the distal vessel. Next one. That's it. So we are going to dilate the track, put down an IVUS. Low threshold for using guide cath extension.
No, the first wire was proximal cap, and it was just used to facilitate balloon delivery, and the balloon was used to trap the Corsair and to compensate for a JR4 guide being used.
But why knuckle was formed?
It just folded. The difference between folded and knuckle, and it's very small as well. The diameter is.
You can back up one, please.
So the balloon was
yeah, back from there.
Yeah, the balloon was, the microcatheter was here, and the balloon was trapping the microcatheter. Okay. So it's called a coaxial anchor.
Yeah, 2.5 longish balloon. And then we'll bring down our IVUS. And then we use that coaxial anchor balloon as our trap balloon, James. So rather than a dedicated trapper, we were able to move it in and out. IVUS coming now. Can you put IVUS up on the main screen, please?
So again, there's quite a lot of large vessel with a lot of plaque. So you can see the adventitia distance here is probably 4, but there's a lot of positive remodeling. This is all plaque here. Huge amount of plaque volume inside the vessel. With a big, at least, I don't know where they are in the pullback, but they're quite high now. Bit of Apache calcification. Getting on for 4.0. RV branch should be coming in soon now. There's your RV branch here.
That looks subintimal there, doesn't it? It's certainly out towards the adventitia.
Intimal.
Uh-huh.
Yeah, no, I think it's intimal, yeah. It's, you can see as you got the cap, it was eccentric, but it was within the vessel border.
Yeah. So it's a 4.0 vessel, isn't it? We're going to have to squeeze the ostium of the PDA and take a picture and decide what to... Leave that connected, please. All the way, diseased. So I think we'll squeeze the PDA, and then we're going to use guide cath extension to deliver a stent down into the PDA and come from the PDA back.
Yeah. We didn't see a PDA, or we didn't see a disease-free landing zone column. I don't know if
No,
missed
I
that.
didn't. I didn't. We'll stop the recording. We'll take that out.
We saw a vessel that was pretty large, even pre-crux,
Okay.
probably getting on for 4 pre-crux, but with a lot of positive remodeling.
Sorry, I'm going to replay. I just reflect. Oh yeah, sorry. Yeah, we couldn't get the IVUS into the PDA, James. So that's as far as we could get. Could you play the first picture?
I didn't see any PDA IVUS. Did you see that?
No, we couldn't get into the PDA.
Oh, right, okay.
Wouldn't go. And there's disease, so we're going to deliver a stent into the PDA. We're going to have to pick a landing zone. There's a 3.5. Yes, we're going to give a squeeze, bring in a guide cath extension to deliver the stent, and because of a JR4 guide, and it's going to be a long.
Yeah, it is. Yeah. I mean, ideally, you want to go from normal to normal, and certainly there's even the distal landing zone. You can see a lot of disease burden at calcium. There isn't an area you'd be very comfortable landing a stent in there.
No, so it's all 4.0 in that proximal right, isn't it? So coming from above down, I think where we started wiring is where it goes out, as you said, eccentrically there. Yeah, so that's eccentric. I think that's the proximal cap, a bit of calcium, and then yeah. So we're going to have to squeeze the PDA and use a guide cath extension to deliver a long stent. Re-IVUS it. 7.5, please. Won't track easily. Okay. Well, why don't we get the Guidezilla loaded? I think James is in the mid PDA.
Yeah, I think the hope is that if the PDA is free of disease, at least you've got a normal to normal. I would have concerns about patency even if you just balloon that, but maybe some sort of combo strategy of stents proximally and dead distally. This is a Guidezilla?
This is a guideliner, yeah.
Yeah, I thought you said Guidezilla, yeah. Just misheard you there.
Why not cabbage for both?
Why not?
Cabbage.
Yeah, I mean, it's not an unreasonable question. I guess the calculation made here is he's got a right and a cert, and his LED doesn't need grafting. So he's going to get 2 vein grafts, and that's not going to be very good age 37 either. So, you know, I think we have to realize that the things we struggle with is durability of results. Actually, surgery is the same issue. A 37-year-old gentleman is going to require repeat revascularization irrespective of initial growth. I think we can't be too arrogant or confident that what we do today is going to be the end of this gentleman's story. And I think all the systemic factors that's got him to this point, age 37, have to be addressed. You know, we actually probably could make a big difference in his outcome by targeting his diabetes, for example.
Just maybe another scenario, like, okay, we crossed with the wire, we changed to the workhorse wire. What's going to happen, like, take a retrograde injection, choose our distal landing zone, put a stent, and then do our imaging?
Yeah, because why would you do the imaging after without knowing the size of the vessel?
Like, estimate the angiogram.
Yeah, you could guesstimate the angiogram.
Like, a 2-5 stents, it can go up to 3-5.
Some people do that pragmatic approach, but if you're going to spend your money in imaging, why not use it to its maximum advantage? Why not assess beforehand and assess after? It doesn't take very long, and the PD looks a bit better actually, doesn't it?
Yeah, so that's how far we need to go, James. That's the landing zone there.
Looks much less free of disease. We had a course not so long
Actually,
ago.
I'm going to pull back.
Stent failure, and we were
No, I
talking
don't.
about the
I live
value of
here.
imaging.
No, I don't.
And one of the speakers said, well,
Yeah.
somebody came to my house the other day to fit the carpets.
There we go.
And he actually measured the house before he
Just
put
go
the carpets
cranial.
down. He didn't just chuck the carpets down. And that looks about 5 by 6, and chuck the
That's
carpets
the
down
crux.
and say, well,
Just sunny that
close
screen and
enough,
sunny.
and walk out of the house.
Sunny.
Yeah, we're putting stents
That's the
into
crux
those
there.
arteries here, so maybe we should get it right the first time rather than sort of guess. It looks about that. I know we have an amazing amount of confidence in angiography because we use it so much, but let's not forget it's 2D silhouette, the vessel, into a 3D structure. It's a poor reflection of actually the real information. No matter how experienced you are, you don't know that information until you actually look at it. I personally don't think there's any substitute for imaging in any form of PCI, but I'm always surprised by how frequently the threshold people use it for, it's pretty high. And I think part of that is because we don't have massive comfort around what we're seeing. I know cost has an issue too, but mostly it's around interpretation and ease of use. And I think if we can improve this, we can probably end up with better stent outcomes.
But James, there's the crux.
I mean, in this case, with pure anti-grade wire escalation, you could use OCT. So OCT does have utility in this situation. And certainly that's what's been tested with CTOs are included in the Illumin 4 study. But I mean, the pictures here are great in terms of the quality of the iris. I think it would be even better if they had the HD iris.
So I'm thinking of a 2.5 long stent, post-dilating up to 3.5 in the distal right and 4.0 proximally. Even in further, just go back to that cine acquisition, just go back a couple. Go back another one. Yep. No, that, can we put that up as a reference? And go to that view, please. Go to that LEO 30. And just see where we are. In a bit more. We're just guessing, Hussam. It's way down, isn't it? Okay, I think we just have to go there. Guide. Yeah. So just go to nominal. Just go to nominal, please. And then as you come back, just come back and we'll post dilate it. Just come down. Can I have a 3.5/48 stent then, please? So just what we do now actually is just a few technical points here. As I post dilate, Hussam's going to slide the Guidezilla into the stent. So as we come down, just so that we don't damage the front end of this stent. Yep. And a 3.5/48. Just replay that. Three five 48. Then take a long 3.5 NC. This is going to be back to the ostium. A 2.5/48 from the PDA back, and then a 3.5/48 for the main RCA. And this, to me, I'm quite happy for it to go up to 4. So just make sure there's no air in the system. We're just going to bleed back. We're going to cine and make sure we're overlapped. Bring the guide out. Get the guide out. Just make sure there's no air. So see, we're just making sure there's no air in the system. Okay. So don't flush it. Don't flush it in case. Okay. And then the 2.5 will go up to 4. I know that's not the on label, the on the box in the IFU. Just send in, make sure we're overlapped. So it needs to go back a bit. So we can come back a bit. Just bring it back. Yeah. We'll test there. Sorry. You're still damped. You're still damped on the pressure. So we're gonna just Cine and make sure we're overlapped. I think we're gonna need another one. Yeah, I think we're gonna need another one. Just come to an LEO caudal. Come to LEO, slightly caudal, just 20 off the diaphragm. Yeah, that's good there. Just that's good. Cine that. Have you a stent boost?
Yes, we do. Give me IC stent.
I think it's in a dot. I think we're going to need a third stent, James.
Ready?
Yeah. It's minimal. It's minimal. Let's go in a bit. Yeah, we're short. We're going to need a third one. Open up first, please. Go back to the LEO. Okay. So no, don't inject. Just put the guide. So 3.5.15, please. You can put the guidezilla in. Yeah. 3.5. Pardon? Yeah, we're going to take another stent for the ostium. We need another. It's okay. We're okay. We don't need the. Yeah. It's the 6 French and the 7, I think. But we're good. Yeah. Just watch the guide. And then a 3.5 long NC balloon, please. So that's where the ostium is there, where that pressure starts to damp. So probably a lot of overlap for this one, but we can get the guide back in terms of, yeah. This is a 3.5. 3.5. Back. Yeah. Okay, so give us a little screen for me. Okay. And then down with the guidezilla and give us the NC balloon, please. Okay, good.
Now we don't have damping anymore.
No, got a good job.
Yeah, thanks.
Just play the setup shots again for me, please. Forward to setup shots. So the Circ has a clear cap.
I'm going to work on this. You can take over and talk about the circuit. You'll be doing the circuit.
Yeah, the crux. Just go. It's quite a bit, isn't it?
Go there. That's aggressive. Walk it back.
And then, yep.
Off bank, please. Off bank.
We need a 2.5 NC, please. Yep, 2.5. Mm-hmm. Thank you.
One more column.
Yep. So put the guide Zilla in 14. 7.
Yeah.
6 French guide. Yeah.
That's right.
Just go up to 2020, please. We should be able to do a picture here, James, see what we've got. Good job.
Give me a regular
Yeah.
mic.
Well, and again, I'm just making sure there's no contrast because we've been using a guide cath extension. Pressure good. Okay, just screen, make sure we're... Yep, it's going to be the classic poor runoff, isn't it, because of the distal disease. Question is, well, whether we do this circ or not today, given that, let's take the IVUS down, just IVUS the outflow. You can make an argument for staging them. IVUS, please. How are we doing schedule-wise? Good job.
Thank you.
How are we doing schedule-wise?
We're okay.
Yep.
Probably want to do that. Can you just see the schedule? You can go ahead.
Yes, you go on ahead. I think we can
Can I do this here?
do whichever you want. But we can, there's no issue staging it. IVUS back on screen. Mag up, please. Mag up. There we go. Mag up one, please. Mag up. Oh, it is. Yep. That could give a little... Come down, Leo, please. Safety wire. So the question is, do we give that a squeeze with a 4?
Yeah, I can do that.
It's a 4 ONC.
Yeah, no, 20. 25 is fine.
Play the IVUS. I'll talk about the IVUS. So there's a distal edge, James, and the distal edge is fine. Four. So 4-0 from down pre, yeah, from there back.
14.
James, we're just giving the standard segment a squeeze with a 4. in the main vessel. The distillage, I think, look fine. Yep. Yeah. So we're going to stage the circ. Yep.
Sounds reasonable. Great job.
Okay. Good. Thank you.